Good morning, everyone. I shall be speaking on a small modification, minor modification of a open sky technique. So my topic is partial open sky method, a novel technique to avoid the open sky condition during Tripl procedure. As a cornea surgeon, despite years of experience, whenever we do Tripl procedure, and in cases of complicated pre-op, the indications, while after taking out cataract, there is always, we may encounter the vitreous push, sometimes iris push, and the most dreadful condition is expulsive hemorrhage. Whatever we try, we give patient mannitol, pre-op mannitol, or whatever we try, it may happen sometimes, and it is a very, very dreadful situation for a cornea surgeon. So there are various modifications have been adopted by various surgeons by putting scleral fixated IOL to prevent that vitreous push or pupillary expansion devices just to control the intraocular pressure and that complication. Here we describe a novel technique modification as a partial open sky technique during this surgical step of trephining and excision of the host corneal tissue. So indications are same except the infective pathology. So these are the small pictorial presentation. Here, after cutting the host tissue, only some part of it, 2 to 3 clock hour, the host tissue is attached. It remains like a hinge and prevent the vitreous pressure. So after taking out the lens, next step is IOL is being put. What is the difference is throughout this procedure we remain 1 clock hour of the host tissue attached as a hinge. Either we can remove it entirely and then suture it, or we can leave it attached, and if we feel there is a lot of pressure coming out, and after placing 2 anchoring sutures, we can cut that host tissue. So it is just a minor modification of an existing technique. This is a small video, short video showing the modified technique. After trephining, the tissue is host tissue is being cut and some part of it remain attached. The nucleus is delivered nicely, and after placing IOL, this tissue is being cut. So throughout this step is increased, so that I have noticed myself that the vitreous pressure remained controlled. So the results are, I've done almost 8 cases out of 23 Tripl procedure in our center last 2 months, and in 2 months duration, and all patients successful CCC lens explantation with IOL within the back was achieved, and the vitreous push and pressure was not observed. There was no complication throughout. Advantages of of this novel technique is that it greatly increases the safety profile of the corneal transplantation for full thickness procedure. There is increased control during cataract extraction. The technique required a negligible learning curve for novice surgeons. There are no complications of vitreous push or expulsive choroidal hemorrhage were encountered, and there is no actually appreciable increase in surgery time, no extra funds or expenditure involved in this procedures. But there is definitely a limitation of the procedure, that our technique is just limited by the fact that this technique cannot be useful in cases of therapeutic keratoplasty on account of contamination of the donor grafts, and for definitive prevention we need to do more number of cases and RCT with a standard technique. Longer follow-up cases are also required for post-op follow-up. Thank you.
One question I have you used IV mannitol before pre-op for all cases?
Sir, in all cases of Tripl procedure or any corneal transplant, whether it is lamellar one also, we have always given IV mannitol half an hour to 1 hour before the surgery.
How does this keeping a hinged cornea there How does it prevent a suprachoroidal hemorrhage? What is the mechanism in your
sir.
opinion?
So, sir, actually, mechanism in scientific thing I cannot explain, but there is some anatomical persistence of the same host tissue, because sometimes I have noticed that there is, beside everything going ideal, there is lot of push from the behind. In those cases, having that hinge, immediately we turn it back.
No, that I agree, that it is a good for your anxiety. It helps you because you can immediately close the wound.
Yes.
That is correct, but it doesn't prevent any. If a suprachoroidal is to occur, it will occur.
Yes.
What will prevent it, as Madhukar says, is mannitol, which you are giving.
Which
A
we are-
flaring a ring in all have a low index of putting a flaring a ring so that you can keep the sclera open. So these things will help more. This is more for psychological help that and ready availability of tissue to close down.
Yes.
And as you said, you can take 2 sutures first. I normally take 3 sutures and then cut off the hinge because the hinge is small.
Yes.
I take 3 sutures. Only the 4th one I take after chopping off the.
Absolutely.
So this is actually it's a fairly well-known technique. It has been tried before. Yeah.
We just call this a sliding graft technique.
Yeah. It's called by different names, but it is there. Yeah, describe. Thank you.
Thank you.